Well, it's 11:30 here in the United Kingdom, and welcome to everyone all over the world to another of our COVID-19 series webinars from the Royal College of Surgeons of Edinburgh. So hello to all of our members and fellows and anybody else who has joined us. It's great to talk to you. I'm Professor Michael Griffin. I'm President of the Royal College of Surgeons of Edinburgh. And I'm here simply to introduce our international vice president, who probably does not need any introduction to you who are joining today, Mr. Pala Rajesh, cardiothoracic surgeon from Birmingham, and he is going to chair this international webinar on international issues related to COVID-19. But I also wanted to just let everyone know, and particularly our members and fellows, that our college is very much open for business. It's open for business virtually. Some 6-7 weeks ago, we had to close the college in line with government plans, and I'm sure you're all familiar with that. And we are very much working from home and remotely, and our IT department has been absolutely brilliant in making this happen. We're open for inquiries, support, help, and particularly for those who are asking about exams and assessment. But in particular, we're open for education, and this is part of it, the webinar program, not just about COVID-19, but across the board. And you're all welcome to join that webinar program. So we are also doing a lot of things to try to help in the community as a college. Our own hotel, many of you have stayed there, 10 Hill Place, is open to support the healthcare workers, the key workers in our hospitals around Edinburgh, and indeed also for patients who are self-isolating prior to coming into hospital to have urgent or cancer surgical care. So we've actually had something like 2,000 days of our hotel providing support for these key workers and for patients. So we really have been very, very effective in doing that. So without anything further from me, I am going to introduce you to our International Vice President, Mr. Pala Rajesh, who will introduce to all of you this outstanding, stellar panel from Singapore, from Malaysia, from Chennai in India, and indeed from Myanmar as well. Okay, over to you, Raj.
Thank you. Thank you very much, Mike. Good morning, good afternoon in India, and good evening in Singapore, Malaysia, and Australia. Thank you for attending this webinar. I am delighted to introduce Professor Sudha Seshayan, Vice Chancellor of the Dr. MGR Medical University in Chennai, India, Professor Hanafia Haruna Rashid, who is the Medical Director at Hospital Kansalor, Tuanku Muritz, UKM Kuala Lumpur and Malaysia, and Associate Professor Kenneth Mack, who is the Director of Medical Services, Ministry of Health, Singapore. Thank you all very much for participating in today's webinar on behalf of the college. The Royal College of Surgeons of Edinburgh has been working tirelessly since the pandemic to help influence national health policy, education, and this through information gathering and advice. We have produced guidelines along with the sister colleges for surgeons in the UK. These guidelines have been shared with our partners in India. We would like to learn from you today how your respective countries responded to COVID-19. We shared a framework to retain consistency during our discussion earlier on. We talked about how we can decide about the month of recognition, the government's response, your Ministry of Health's response, the present situation in your countries, and your plans after lifting lockdown in your own respective countries and an exit strategy. After your presentations, I will take questions which will be coming in from the viewers, and round off today's webinar by asking each one of you what your plans are for the new normal by way of education, examinations, quality assurance, and maintaining professional standards in surgery. So thank you ever so much for participating in today's webinar. I now hand over to Hannah for his presentation. Thank you.
Thank you very much, Mr. Vice President, and ladies and gentlemen from all around the world. It's evening here in Malaysia. I know it's morning in Edinburgh. We're all here to share the response, how Malaysia did it over the last 4 months, I think, since the epidemic or the pandemic has been declared. Now, I think I have some slides. Ryan, have it there. I'm not sure whether you can see it, but in brief, Malaysia is actually in Southeast Asia. For those who have not been to this country, we're just to the north of Singapore. We're divided into 2 parts. One is the Peninsular Malaysia, which is actually connected to Asia, the mainland, and the other one is the East Malaysia, which is connected to Borneo, which is part of the Borneo island. Now, it is quite a diverse country. Malaysia is a country of contrast. Within the big cities, it is as modern as Singapore or any other part of the Western world. But in some of the remote areas, we'll find that the facilities and reach is not as good as the one in the big cities. We first had our first case declared in January, 25th of January. I think there are actually Chinese tourists that came through Singapore. And since January to February, I think the cases are all limited to people that just come back from China or they are of Chinese citizens. So at that phase, that we thought that we can manage to contain the disease. It is just by the end of January and February, in fact, it is just about 20 cases that we had. Unfortunately, something happened at the end of February. There is a big meeting. Next slide, yeah. I think this is where Malaysia at. This is the story. Yes, today we have 6,000 over cases. In fact, the latest is about 6,726, just been announced by Hisham, our Director General of Health, and 109 deaths. Now, just go back to the next slide. Next slide tells you how we started. The first case in January, initially with 3 cases, then 8 cases, and then subsequently just in double digits. Next slide, we can go on. Yeah. But what happened, 2 things happened at the end of February. I think one is that we actually had a political crisis where we changed prime minister without an election. I'm not sure any other country in the world actually had changed the government in the middle of the COVID crisis, but we did. And at that moment, I think it worries everyone, because the tendency is for people to go on the streets and demonstrate. Luckily, that did not happen. And I think that was the good thing about us. We managed to stay sensible at that time. Now, another thing that had happened is that there is a major religious gathering that happened in Kuala Lumpur. That gathering had 16,000 participants, 1,500 of which come from the countries of ASEAN. I think later slides, I think we can just go through very quickly. And that had subsequently changed the game from the containment phase to the mitigation phase, because we suddenly realized that people has gone to all over the country, and every state have got cases. We had to act very fast. Indeed, the government, the new government had declared our own lockdown, which is called the Movement Control Order, on the 18th of March. So on the 18th of March, we had to declare that, because within a week after we knew about those cases, it suddenly go from 20s to 80s to hundreds. And we had to actually do what at that time people thought it was draconian measures. Within a week of the election of the new Prime Minister, the new Prime Minister had to declare this. So there's a complete restriction of movement and assembly nationwide. There is a travel restriction. There's a complete restriction of foreign visitors and tourists into Malaysia. We had to close schools. The next slides, I think we had to close schools, close universities, close the public universities, and close all government and private private premises, apart from some very essential services like the hospitals, police, and banks. We then go into chasing all the clusters. We found a few clusters, some of which are derived from that meeting in Sri Petaling, which is the religious meeting, but some of which are not. And they are divided into those in the slides you can see. Our public health team has worked tirelessly 24 hours. We in the hospitals, in our university public health department from the Faculty of Medicine also helped the government, the CPRC, the Center for Preparedness and Crisis Management, to actually chase all these cases. In those areas that we find that there are high number of cases, we actually do a very tightened control movement order called the ECMO. This is very enforced, where we actually test everybody and nobody comes out and in of that particular area. The rest of the country had to undergo what we call the CMO, phase 1, phase 2, phase 3, and now we at the end of phase 4 going into phase 5. In May, after the Labor Day, the government has declared what we call the conditional movement control order because of some two things. One is the economic pressure. We feel that there's some of the economic sectors need to actually kickstart again. Many business will go bankrupt. Many people will lose jobs. The unemployment rate is already 8%, but with very, very, very strict guidelines that they have to follow. If they don't follow, they have to get it closed down. Even then, I think the Academy of Medicine and some of the medical groups actually made some statements of cautions, thinking that whether the public will abide to those rules. This is a race. We know it's a race, but the government is now shifting the responsibility partly to the public to be responsible, and because we feel at the end of the day that unless there is public engagement and public involvement in taking the responsibility of social distancing, taking care not to spread the disease, we will not win this war. We know that the MCO cannot last forever. We know at the end of the day, the game can only be won if we actually find a vaccine and find a cure for this disease. So for the time being, we have to enforce a very strict public health measures, and we feel that one day it has to stop, and one day we need to develop the herd immunity. The MCO is done to actually buy us time so that we don't get too many cases that overwhelm our health services. We managed to flatten the curve. The JP Morgan thought that we are going to have the peak in mid-April of 6,500 cases. We managed to delay it by 3 weeks. We just managed to reach 6,500 now, a few weeks later, almost a month later. That means that we have actually managed to save 1,000 beds, because by mid-April we only had 5,000 cases. That's equivalent to 2 big major hospitals. So I think that's all. I don't want to go into too many details. In March, we in Southeast Asia became the country that actually has the most cases, 3 times more than any of our neighbors. Now we managed to actually reduce it to the numbers, respectable numbers, where we are number 51 in the world, one of the lowest daily cases, by implementing those strict measures. We only have, I think, how many? About 13 cases in ICU. We have 1,000 ventilators available in the country, and we have 40 hospitals dedicated with almost 4,000 beds. Our hospital is one of the hospitals chosen. We've been busy until the past week, which we can actually manage to rest some of our front liners. We're still trying to do as many tests as possible. The DG of Health aim at 16,500 tests a day. We, I think, managed to reach about 15,000 a day for the time being, utilizing all both public and private hospitals, labs, including the 10 university hospital labs, and we are helping the government. So this is an example of how extensive contact tracing has been done. We are proud that the last few weeks we don't see any random cases in the community. All those cases reported by the Ministry of Health daily for the last few weeks are all within the EMCO. So we've managed to actually, they all come from our quarantine areas. We are actually testing them extensively. We want them to be positive so we can take them out and then treat them very early. Next slide. I think our exit strategy will be done carefully by stages. We are now in the what we call the conditional MCO stage. It's been declared by our Prime Minister for until June the 9th. I suspect that it might be extended for the next few months, relaxing some restrictions, looking at the number of cases, but it's yet to be seen. I think we are still getting our fingers crossed and see within the next few weeks what's the effect of our CMCO. I think I should stop there. The last slide is just showing what happened in our hospital. I'm more familiar with what happened in the hospital because we are right on the ground. When we started, we actually divided our emergency department into areas where you can see it's all cordoned off. Some COVID negative cases will go in through one door. The SARI cases or the ILI cases will go through another door. The COVID positive patient will go to another door straight to the wards. We have 205 cases treated in the hospitals. It's been reducing by the day. We have very strict, we are now into the 5th guideline produced by Ministry of Health, strict guidelines on surgeries done. PPEs must be worn. We have enough supplies to last us for another 2 months. And I think on behalf of our frontliners, we'd like to say thank you very much to the Malaysian public for adhering to our advice. And I would like to also congratulate the governments for managing to actually come in with a press conference every day. So I feel that the public is very engaged. I can sense the difference. When we started in February, if you were going to say that we're going to have a MCO, movement control orders, everybody say, what is that? And they don't believe that it should be done. Today, when we announced that we are going to relax it, we find that the public themselves are very, very concerned about it. So I think we somehow managed to turn the public from being ignorant into the public that actually reads and actually wait for the press conference every day. That's all I've got to say from here. I'm willing to answer some questions. Things are dynamic. What I say today might be right, but tomorrow it might sound wrong because there might be a different strategy. Thank you.
Thank you very much, Hannah, for your comprehensive presentation as to what is happening in Malaysia, how you have tried to contain it, and your future plans. It's interesting that the public seem to be participating extremely well with all of the governmental decisions which have been taken. I now request Ken from Singapore to inform us as to what is happening in his country.
Thank you very much. Thank you very much. Shall we start with the first slide, please? This is an epidemiology curve that tells you a little bit about the story in Singapore. This would reflect data as of yesterday, and we had just over 23,000 cases in total, of which we have just over 1,000 patients still being managed in our hospitals, 22 patients in the ICU. We've been very fortunate not to have many deaths. In fact, 20 deaths as of yesterday, out of the entire population of 23,000 over cases in total. And I think that's something that we continue to be very cautious about. There are many patients that are still in the hospital being treated, and that number may evolve, but certainly that's the data that we have right now. Can you go to the next slide? Yes, this is a story really of how COVID evolved in Singapore. We have a system of surveillance that we put in place in Singapore, tracking events that occur internationally. And this was put in place after countries in Southeast Asia had an experience with SARS. And we were quite keen on making sure that we were able to track developments that occurred in other countries around the world, particularly of outbreaks that will occur, novel new diseases, which could potentially spread very easily given that many countries are travel hubs. And therefore, it came to our attention sometime towards the end of November about a mysterious cluster of cases occurring in a city in Wuhan, in China, of influenza-like symptoms being manifested. And in fact, because of that, we stood up a task group looking at this issue as early as the end of November, beginning of December. And this is somewhat of a unique situation because, in fact, we started putting in preparation, activating some of our infectious diseases measures even before our first case actually occurred in Singapore. This was not just confined to the Ministry of Health. In fact, just after that, with the start of the new year, we brought this up also to the rest of government. And a whole of government task force was in fact stood up to explore how we should prepare for this just over a week before that first case came. So in fact, we're one of the few countries where we stood up our preparation even before that first case. Hannah talked about the first case in Malaysia. And in fact, our first case occurred on January the 22nd, part of the same cluster. And this marked the first phase that we experienced in Singapore. We had a total of 18 travelers coming out from China, particularly from the province where the epidemic arose in China. And these were travelers, including a tourist group. One of the members of the tourist group became our first case, but several members of the same tourist group then traveled on to Malaysia, visiting a theme park in the southern part of Malaysia. And then, after information that was passed on, they were all put into isolation. And when tested, their first case in Malaysia then was revealed through the test done in Malaysia itself. So in fact, we were linked in terms of both our outbreaks through the same tourist group that traveled out from China. And we had 18 cases of travelers from China in that first wave of importation. This prompted us to be one of the first few countries to start putting out travel restrictions. And our travel restrictions were against travelers coming out initially from Wuhan city, followed by Hubei province, and then extending eventually to other cities in China as the epidemic took root across many countries, many cities and provinces in China. You may remember that the epidemic occurred in China at a very important period of time in the Chinese calendar. And this was before they celebrated the Lunar New Year, where there would be mass migrations of people traveling throughout China. And this was a worry for all of us in the public health setting because of the fear, therefore, that in fact, the outbreak would not be confined to a single city or province, but then would spread very quickly as mass migration took place. And because we had many people working in Singapore that hailed from China, we were also very concerned about importation. This led, of course, to many different responses occurring in China. It led to very drastic lockdowns of cities and provinces, which had never been seen before. But it also led to us putting that first travel restriction against travelers coming up from China. And while those travel restrictions were put in place, we started, in fact, a serious surveillance of people who were already in the country to determine whether there were any people who were having symptoms. And if there were, we would start to test them. The next wave of cases we experienced, in fact, came out of those original cases, because from those travelers that came back from Singapore, to Singapore, we started seeing clusters that started to arise. Many of these clusters were related to travelers coming back, a mix of people, including tourists, those who were on work permits, coming into Singapore for work reasons. And we also started to see various other cases occurring as a result of evacuation flights that were mounted to bring Singaporeans back from China as well. We screened all of them when they arrived in Singapore, and we picked up a few positive cases as a result. And so that led to that second phase where you can see this particular chart on the second graph, a few cases starting to occur through January and February. But it was with, in fact, aggressive early detection through testing, isolation, then contact tracing and ring fencing of those who were close contacts with quarantine, that we managed to keep the numbers low. The third phase we had, in fact, arose as the epidemic started spreading to other countries. And this led to other countries, particularly in Europe. You may remember then the outbreak starting to occur in Italy, other parts of Europe itself, and also in the UK. We started to see an influx of many people coming back to Singapore. They were mainly Singaporeans who had been overseas for work or study reasons, and they all flocked back, partly also because those other countries started closing their borders, shutting their universities and schools, and they all came back. And it led to a large number of cases starting to occur as a result of these returning travelers. And this accounts for the blue peak that you start seeing in the middle of the graph, the first graph, from imported cases. We further impose stay-home restrictions, isolation restrictions for 14 days for all returning travelers as a result. But there was some spread in the community as a result of these imported cases, and that led then to a number of cases arising in the community. It led, therefore, to us having to impose various additional restrictions, not just in terms of travel and isolation of travelers returning to Singapore, but it also led eventually to the imposition of community-based lockdown measures. We were perhaps somewhat late in imposing many of these measures, because until sometime in the end of March and early April, in fact, we had, a limited community spread, and therefore there wasn't a need to impose these measures until towards the end of March and the beginning of April itself. There were unique clusters that started to form, and these were not necessarily localized to a geographic setting, but in fact were more characterized as a result of social activities. So for example, we saw a couple of clusters arising in churches as a result of the close interactions that occur in small group settings, whether people were coming together for Bible studies or otherwise, which led therefore to clusters emerging in these settings. There was also clusters occurring as a result of social activities. We had many senior citizens engaging in social pastimes, including group singing activities, karaoke sessions, and clusters starting to form in this particular setting as well. And we in fact had to stop many of these social activities in order to allow for more effective ring fencing and control of those clusters. But what led to a huge surge in cases that took place towards the end of April were in fact a transmission that took place among the foreign worker community in Singapore. And in this setting, we found in fact we were vulnerable because of the setting in which these foreign workers were staying in and working in. For example, the accommodation that they were staying in was somewhat dense as far as the population is concerned. We have several dormitories, in fact, that would house anything between a few thousand to as much as 13,000 people in a single dormitory. And they'll be living in purpose-built dormitory settings where they would stay several to a room, but they're sharing communal facilities, which includes eating, laundry, kitchen facilities, and a lot of mixing and close contact that takes place. In fact, the design of these dormitories was intentionally intended to give them a communal, this ability to have a communal lifestyle among like workers in that environment, so as to give them a sense of home away from home as they were working in Singapore. But these then proved also to be opportunities for close contact and rapid spread of infection taking place in the dormitories itself. Also, we would have workers working across, living in different dormitories, but coming to the same workplace to work. And therefore, as they were working and interacting at the work site, some of the work sites then also created portals for further transmission to take place, and therefore leading to not one, but several dormitories then also seeing clusters erupt. And once a cluster erupted and took root, it became very difficult, therefore, to stem that mode of transmission within the dormitories itself. It's also partly a cultural issue that many of the workers, in fact, were somewhat reluctant to seek care. And this is in part also was because they were fearful that if they were taking a lot of time off work and they were sick, having a lot of medical leave, then this would perhaps lead the employers to consider ending their employment or even repatriating them. And therefore, this fear factor led, in fact, to many of them delaying seeing a doctor, seeking medical attention. And because of that, it also led to a late detection of many of these clusters within the dormitories. And by then, you then have several generations of spread that could have taken place, a cluster being much bigger than what it would otherwise have been if there was an opportunity to intervene early and prevent amplification of an outbreak taking place. So while in the early stages, we were somewhat effective in managing to contain community spread, local clusters that were occurring through basic primary health measures, early detection, contact tracing, isolating. In fact, it was very difficult to do so in the challenging environment of the dormitory. And because of this, we now see a somewhat unique situation where, in fact, we now see two different outbreaks occurring simultaneously in Singapore. If you move to the next slide, this gives you a sense of what I mean. And as a base, you see large numbers occurring in the orange part of the slide, and that reflects, in fact, the outbreak that we are currently managing among foreign workers living in dormitories. When we look at the bottom of the graph, you'll see a beige set of beige bars. That reflects, in fact, what's happening in the community right now in terms of spread. And if you're public health and epidemiologist, then you'll be very familiar with the concept of an effective R value. In fact, in the community, it's less than 0.5. And in fact, with effective containment and contact tracing and isolation, we in fact are quite confident that we can continue to control what's happening in the community at large. And that reflects one end of the spectrum of outbreak management we're dealing with, while concurrently we're dealing with a huge surge of cases occurring within a very closed environment in the dormitory. And what we have been trying to do is to separate out these two outbreaks, prevent admixing, preventing cases spilling across from one setting to the other, and therefore causing more problems with further amplification of cases. If we move to the next slide, I'm just going to take you through some of the aspects of how we've been managing the outbreak, and this may perhaps be of interest to some of you living in different countries and different settings. With a suspect case definition, which leads our doctors to have a high index of suspicion when dealing with a patient who presents to them with symptoms that may suggest the presence of COVID-19. And that has evolved through various versions as new information comes in. In the past, this was predominantly related to a history of geographic travel, particularly of countries which had COVID-19. But now we've evolved that case definition predominantly looking at those who have community-acquired pneumonia. At one stage, we're looking at those with persistent acute respiratory symptoms, but we progressively now move to anyone really who's got acute respiratory symptoms in a setting which leads them to have an exposure with a case of COVID-19, or working in a setting which leads them to have a high risk of exposure, and we would then test them very quite aggressively to look for this. We have a system in the country for sentinel surveillance as well, and that occurs through our primary care clinic networks, where they also would be testing quite a number of patients as they present for acute respiratory illnesses to get a sense of how much community spread is taking place. Sentinel testing also takes place in our hospitals for anyone with pneumonia and with sudden death or suspicious death under suspicious circumstances to get a sense of whether or not there are cryptic spread of COVID-19 in the community. So that is the baseline for surveillance, and we complement that with testing being done in our primary care clinics and dedicated screening centers for any patient who presents to them with these who fulfill the criteria as dictated by our suspect case definition. At this point in time, we use PCR testing for diagnosis. Early on in the outbreak, we were fortunate to have a National Center for Infectious Diseases with a strong public health laboratory. And as the information came out from China, including information about the viral genome, it allowed us, in fact, to produce our own local PCR test. And very early on in managing the outbreak, we already had a capacity of being able to carry out 2,000 tests in a day. Currently, we're performing something in the order of 7,500 to 8,000 tests daily for the various different settings I've mentioned. And we've performed something in the order of about 30 over 1,000 tests per million population. So that's how aggressive we are in terms of testing for diagnosis. Next slide, please. Our principles on managing the outbreak still relate to making sure we can contain and isolate the outbreak. We still have border controls in place. And for those who continue to come into Singapore, while the numbers have shrunk as a result of the travel restrictions, there are still returning Singaporeans and Singapore residents who come in, and they all are subjected to a mandatory 14-day quarantine. And they are tested at the end of quarantine to make sure then that they're not harboring infection while asymptomatic before they in fact are able then to return into the community. We've also locked down all the dormitories in order to separate out the community setting from the dormitory setting to prevent spillover infection from the dormitory setting into the community. We do have workers still who originally hailed from the dormitory working, and they are in the essential supporting the essential services and the infrastructure that we need. But they undergo a regime of regular testing as well for us to sieve out and identify those who might have COVID-19 infection while asymptomatic or minimally symptomatic. For the last month, we've had a community lockdown, which was intended to reduce further circulation in the community and therefore reduce the risk of further transmission of cryptic infections in the community. I mentioned a bit about quarantine and contact tracing operations. And as Hannah had mentioned earlier, we are using technology aids, including technology aids to facilitate contact tracing. It's the same technology using mobile phones, Bluetooth tracking to determine who a person might be in close proximity with, and therefore using it as an adjunct to help us identify close contacts that we then need to quarantine. We isolate all confirmed and suspect cases, as opposed to other countries where on the basis of symptoms, they may require people to self-isolate. There's still a policy to admit all confirmed cases either into our hospital or community care facilities that we have raised. In the dormitory setting, we're setting up dedicated in situ isolation facilities so that cases of confirmed COVID-19 infection can in fact be isolated even within the dormitory quarters themselves. We believe that it's important to help to reduce the risk of mortality and adverse outcomes if we can identify high-risk cases or those who in fact have high-risk features where if they get infected, there is a higher risk for mortality and adverse outcomes. And we aggressively try to decant foreign workers who are above the age of 45 and 50 out of the dormitory setting when there are clusters available. And for those who are eventually diagnosed and as COVID-19 infected, they're all admitted into our hospitals for closer surveillance and management. We found in the natural course of a disease that in fact there are many who are minimally symptomatic in the first week, but where they would acutely deteriorate, requiring oxygen therapy and in critical care would be really towards the end of the first week, roughly around the 5th to the 10th day, where we need to be particularly vigilant and where the risk of deterioration occurs. And therefore we aim to intervene as before they in fact reach that stage, tracking and monitoring them, and where necessary then providing them with early interventions in the hope of then minimizing the likelihood of complications and death. It's difficult to tell whether these measures have contributed to our low mortality rates, but we believe that the low mortality rates are also driven by the case mix of cases that we're seeing right now. Because in the foreign worker dormitory setting, there are much more younger people that are affected, whereas in the community-based setting, we're seeing much older people also being affected. And those who have unfortunately passed on, and the majority of patients in the ICU are in fact people in the older age groups. We've talked a little bit within our public health and infectious diseases communities about how we should track their progress and at what stage we should de-isolate and eventually discharge them, deeming them recovered and returning them back to the community. In the past, when we started the management of the outbreak, we were continuing to use PCR tests to diagnose people who have fully recovered and are ready to return back to community. And that required 2 consecutive negative tests performed at least 24 hours apart in patients who in fact have now minimal symptoms or have settled all their symptoms before we return them back to the community. And this continues to be the discharge criteria we use for local residents. But in fact, the local data we've had coming out from our National Center for Infectious Diseases has shown that in fact, we're not able to culture the virus after the first 2 weeks of the course of illness. Within the first day 14 of illness, about 30% of our patients would be PCR negative, but it's only at day 21 it's about 80%, day 28 it's about 95% who are PCR negative, but there's still up to 5% at day 28 who continue to have persistent viral shedding as a result of PCR positivity. But because they are not isolating the virus within the first 14 days, and this is often associated with a very high cycle threshold for those of us who are doing PCR testing, we believe that they are not infectious anymore beyond the first 14 days. And this would be irrespective of whether they continue to shed virus through a positive PCR test. And the PCR test would then perhaps show evidence of viral fragments, but these may not be viable. So we're moving into a situation where we are isolating them in a close monitored environment for the first 14 days, and then progressively moving them into step-down facilities where they will continue to be isolated for another 7 days and only allow, for example, our workers in the dormitories to return back to work after 28 days from the onset of the illness. And we believe that this is a safe approach in our community without requiring PCR testing. And this is something we're moving to in terms of our de-isolation criteria and discharge criteria. The next slide, please. We've spent a lot of time talking about managing capacity because as you've seen the numbers we've described earlier, these are large numbers. But the majority of people who are COVID-19 infected, in fact, are not staying in our public hospitals. And we're reserving our public hospital capacity really for those who we believe are having higher risks of adverse outcomes for more vigilant monitoring and treatment where needed. We've expanded the capacity progressively, including converting what were reserved facilities and spaces and repurposing them as negative pressure isolation facilities and ICUs. And in fact, that has allowed us already to triple our ICU and isolation capacity with an ability to continue to surge even beyond that. We've also created at short notice temporary community isolation recovery facilities. In fact, I have a capacity of more than 14,000 spaces in these community facilities to allow us, therefore, to accommodate those who are recovering from COVID-19 infection, particularly those who are young with minimal symptoms and have a mild course of illness, without needing them to be admitted in the hospital and take up precious ICU and hospital beds. We've also progressively been expanding our diagnostic test capacity to the extent I mentioned earlier, and that also involves both procuring additional test kits from overseas, but at the same time expanding our local production capacity for testing. We've worked on public-private collaboration, so the private hospitals in Singapore also contribute to the national effort, and they contribute in a variety of ways. For example, some of the private hospitals, in fact, accommodate our patients as they are transferred from the acute hospitals in a step-down manner. They also contribute additional ICU capacity for us, although in a more limited setting. And their labs are, in fact, part of our national testing capacity. So we have many of them also contributing manpower to staff medical teams that, in fact, currently are cited supporting the dormitory operations. We've reduced non-essential healthcare services for the last 6 weeks. And this comes with the primary benefit of freeing up additional resources for the outbreak management, but comes at a cost because we are fully aware that there are many patients with chronic illnesses that over time may in fact see their chronic illness get out of control. And there will come a time where we need to balance managing the outbreak with returning people back into the hospital to manage their chronic illnesses as well. We think we are going to reach that point very soon. And that means starting to restart up healthcare services that otherwise have been temporarily suspended. And we have to manage that very carefully to make sure, therefore, that we are able to accommodate both the needs in managing this communicable disease, while at the same time dealing with the other needs of the population in Singapore. We've been expanding our manpower to support the national effort, and that includes particularly returning people who previously were in the workforce. For example, those who previously were ICU trained, but now had moved on to other jobs, other positions in healthcare. And we've been encouraging them to return back into the workforce, giving them refresher training in order to be able to stand up additional people to support the additional bed capacities that we have put up in place. And we've also been working at measures trying to preserve the healthcare workforce. Many of the staff that we have been working for long hours, for long periods of time. In Singapore, we've already passed the 105-day mark for sustained activity in all our hospitals. Fatigue becomes an increasing concern, and the mental health of our workforce also is an important concern. And therefore, these are issues that we're starting to look at in order to make sure that the efforts we put in place remain sustainable. Next slide, please. Public engagement and communications is important, and Hannah has mentioned that earlier as well. We do regular briefings, and many people who watch the television in Singapore have seen me. We have press conferences at least twice a week, and at one stage we're doing even daily conferences. And they serve to engage the public. We don't just simply give them figures about the number of people who are infected, the number of people who recovered, the number of people in ICU, the number of people who passed on. But more important is to share with them where our concerns are, where we think we're going, what the strategy is. And the idea is try to create a level of engagement that allows them to better understand why they have to be put under a restrictive set of measures to limit their ability to move freely in the community. It helps, but nonetheless, it's difficult because the longer you keep people behind doors, the higher the risk of cabin fever, the higher the risk that people would start being fatigued themselves, they'll cut corners, and it's difficult to get people to be compliant all the time, even with wearing a mask, with meticulous hand hygiene, when they have to keep on doing this day in, day out, and they're not healthcare trained. There's a separate set of engagement activities we've found that we have to do with healthcare workers because they need to be also engaged to know they're part of a bigger picture. It's very easy for them to be discouraged, demoralized, if they only see their part of the woods and they don't actually see what we're doing to improve things for them as well. And for that, what's important, engaging the healthcare workforce. I found that I've had to also raise many different work groups looking at how we can promote research, which has not just short-term, but also mid to long-term application in the work that we are doing. So for example, understanding the biology of COVID-19 infection has allowed us to tweak our diagnostic policy, but also our policy and strategy on how to de-isolate and to discharge. We're still looking at how to improve our diagnostic testing strategies. Work streams looking at vaccines and therapeutics, and we've been engaged in several prevalence studies because we needed to have a better understanding what is the extent of spread in Singapore. Everyone's concerned about whether or not there's asymptomatic carriage and whether these people are in fact infectious, and it's important for us to look at this. In a study that we've done so far, we did one sweep of 9,600 healthcare workers supporting residents in nursing homes. We found only one positive result in an asymptomatic individual. And therefore, that gives you a sense, perhaps, that in settings in Singapore, perhaps the community spread really is very, very low. And that gives some level of public assurance when people know of these figures as well. But as it goes on, we need to continue to be vigilant. We need to continue to keep a watch on how outbreaks are progressing, not just in the country, but also overseas. Hana comes from Malaysia, which is our regional neighbor, but we share common borders. We also have other neighbors where they are themselves also having difficulties managing COVID-19. Track on what's happening because eventually, as we return towards normalcy, we have to reopen our borders. And as we reopen our borders, we need to have a sense of what that threat is for cases to continue to import back into our own countries, whether it's to Malaysia or whether it's to Singapore. Next slide, please. So we are currently engaged in this conversation about what it means to return to normalcy. And within that, there are several considerations that we have to face. The first is talking in terms of when the right time is to lift lockdowns. And there are reports now coming out from China and Korea warning about the possibility of a second peak starting to occur as a result of cryptic infections occurring in the community or importation that occurs from other countries. And therefore, this is something that we are very mindful of and which makes us very cautious about wanting to lift lockdowns. And if we do that, it's likely to be in a very progressive, phased manner, always keeping in mind what the situation is in the country. Lockdowns cannot be lifted unless there's a measure in place that helps to continue to prevent further spread. And therefore, safe distancing precautions, minimizing the exposure have to be put in place before we can actually lift these restrictions. And these are things that we are working on. Because of the two different outbreaks that we're seeing, and as I showed you in the graphs earlier, it's two completely different pictures, what's happening in our dormitories as well as what's happening in the community. Even if we think in terms of lockdown, we still need to put in place measures that prevent spillover infection settings. And this is something that we are thinking through in terms of how we should work on that. Protection of the vulnerable must continue because these are concerns that we have. And the vulnerable include not just the old, but those who are living in cohorted settings, who may be immunosuppressed. And it's important that we continue to protect them. In my next slide, I've also put in a few other considerations that we're looking at, which includes exploring the role for community testing. We, at this point in time, haven't committed to any widespread community-based testing regimes. in part because we still believe at this stage that there's still a significant benefit for targeted testing approaches, particularly in areas which yield more results. Also helps inform our further strategies. While we are fortunate to have a significant test capacity, at this point in time, we still feel there's a need for being prudent and not to waste those tests. And if the rate of community spread is indeed very low, then doing widespread community testing would in fact yield very, very low results. We've started to think in terms of what we want to do is rehabilitating the recovered in terms of when we think it's appropriate for them to return back to work and how we would manage them if they ever come back to us with symptoms again. Because it may not be necessarily the case that PCR tests for diagnosis would be appropriate once you've actually recovered already. So these are things we're looking at. The question of whether or not we should be waiting for vaccine or herd immunity is something that has been debated. But it's a bit of a trick question because vaccines are really not something that we have available coming soon. And we don't also want to hinge our entire strategy on the promise of a vaccine being available in the short term. Perhaps it's the pessimist or pragmatist in many of us. We don't think that a vaccine is going to be commercially available to us beyond the next 12 to 18 months. And even if vaccines were available, there will be so much global competition that we may not be able to get vaccines into the country in sufficient numbers to allow for mass population vaccination. And for herd immunity, we think that with an active containment strategy that we have, with the low numbers of community spread, we will never reach a stage where we will get immunity. And therefore, this is something that we don't think is reasonable for us in Singapore. If we had embarked on this approach, the cost to us by virtue of the large number of people who eventually will come into our hospitals and use up our ICU resources would be too painful for us. And therefore, herd immunity as an approach is not something that we would favor. The management of the outbreak has revealed long-term vulnerabilities, and I think this is the same in all our countries. We've realized that our infrastructure may be geared for of diseases, illnesses, but for an illness that is highly contagious, the way COVID-19 is, none of our countries and healthcare systems really have infrastructure that's completely robust that leads to us being confident to say that we are entirely resilient and able to handle it without any issues. And therefore, we will eventually need to deal with the long-term vulnerabilities, just as we did when we confronted SARS and put in the infrastructure that, in fact, now is very advantageous to us as we manage COVID-19. So I'll pause here. I've mentioned quite a bit. I'm quite happy to take further questions later in Q&A. Thank you.
Thank you very much, Ken, for, again, a comprehensive review of how this pandemic is being handled in Singapore. I see a lot of questions coming on, and we will now request Sudha to give her version of what is happening in India, especially in south of India, where the infection rate, I understand, is slowly creeping up. Over to you, Sudha.
Dr. Rajesh, and I come from India, and I come from Tamil Nadu, which is one of the southern states of India. For those of you who may not be aware of the geography of India, Tamil Nadu has a population of about 73 million, which is almost France sitting inside India. And the total Indian population is around 1.34 billion. The first case in India was reported in one of our neighboring states called Kerala. And it was on the 30th of January. That was a student from Wuhan. A girl, an Indian girl who was studying in Wuhan. She came back from Wuhan and she was found positive. That was the start of the entire thing in India. As far as our state, Tamil Nadu, is concerned, our first case was reported in the first week of March. Until March, we did not have anything. Sometime around the 7th or 8th of March, we had the first case. And after which, the number of cases was slowly going up, not actually peaking. And by March 24th, we had the first lockdown, a period of lockdown for 21 days, which was subsequently extended by 19 days. And now we are in the third phase of lockdown, which we expect to be lifted on the 17th of May, meaning 54 days of continuous lockdown in the whole of the country. As on 11th of May, our state, Tamil Nadu, has had about 7,200 positive cases with a death in 47 cases, which means our death rate is just about 0.6%. And whole of India, as of today, we have about 67,000 cases and death being 2,212. We have 28 states, and we find it is not the same. The picture, the scenario is not the same in all the states. There are some states where we have had more number of cases, and as Dr. Rajesh pointed out, due to the early lockdown, South India had fairly contained, and our cases are peaking up only now. And there are two reasons for that. As someone mentioned, there was a religious convention sometime in mid-March in our capital city of Delhi. And many of the cases could be traced, many of the positive cases could be traced to this religious convention. People from various states had attended this religious convention, and when they came back, many of them were found to be positive. So contact tracing was effectively done. If we could stage COVID-19 in India, the first phase was imported cases, very few cases, travel history, people who came from various countries, including China and Italy. Then the second phase was contact transmission, where these imported cases, these travelers had spread it to their close contacts. And after which we found, even during the lockdown, probably we slowly migrated into the third phase of community transmission. Fortunately for us, many of these positive people are still asymptomatic. We have seen about 80 to 85% of our positive people, seropositive people, are asymptomatic. One of the recent trends in the last phase of lockdown, we've had in the city of Chennai, I suppose Dr. Rajesh would be able to understand this. In the city of Chennai, we have a market, a vegetable market. During the time of lockdown, this vegetable market was kept open only for a restricted time. Even in that restricted opening of the market, we suddenly found many of our cases had some kind of contact to this particular market. Either they had gone in and come out, or people who were selling vegetables in the market. And we find in the last 1 week, our cases have been peaking up. Still, fortunately, many of them, because of contact tracing, they have been tested. Otherwise, they are asymptomatic. And as far as our state, as I told you, we find the recovery rate is somewhere around 32 to 33%. And there are some states in India, states which are in the northwest, states like Gujarat and Maharashtra, the recovery rate had been very bad, much below 20%, and the cases again are peaking up there. The neighboring state of Kerala, wherein was the first case, the girl who came from Wuhan, they have contained very well, and we find their recovery rate is around 94%. one of the reasons that we can attribute for that wonderful containment at Kerala is that it is a hilly terrain. So naturally a little less populated in certain areas, and physical distancing probably is a natural factor. India is a largely populous country. So whatever kind of restriction is laid on paper with regard to the physical distancing norms, it is not all the time possible for physical distancing to be implemented. That one of the reasons is what we think as the causes for the cases to be peaking up at this point of time. Now, with regard to our hospitals started their capacity building exercises sometime in the end of January, when the other countries started reporting. Our public health system, our medical services system woke up. And as of now, most of the hospitals which are managing COVID cases have not been admitting people with other ailments. As Professor Kenneth marked out, many of the other cases have been asked to stay home or asked to leave the hospital and come back only after the COVID issue settles down. Right now, we anticipate that soon after the lockdown is lifted, the medical care facilities, healthcare facilities would be opened up for people with other ailments too. And when we analyze the death statistics, the mortality statistics due to COVID-19 in our setup, we find people with comorbidities are more affected, and even symptoms seem to appear only in people with comorbidities. And public awareness had been quite good. The public have been told about the various restrictions that they would have to follow. But as I told you, since we are a very largely populous country, it is not all the time possible to maintain the social norms. Contact tracing is very effectively done by the government, and one of the attributes for a low rate in India until now is because of the early lockdown. The plans for lifting lockdown, we still are not completely aware of what is being thought of, because this is a country with 28 states. This is a federal setup where some of the states do have a say in certain matters. So this is not very easy to just give one simple order. So probably in a day or two, we anticipate some kind of an announcement from the government with regard to the loosening of the lockdown. We anticipate it would be a loosening of the lockdown with restrictions in place. And with regard to the number of testing done, as on 11th May, 9 a.m. IST, which is just about 7.5 hours before this, it was about 1.7 million samples have been tested, which of course is not a very large number when compared to the population of the country. But there seem to be some kind of factors which are favoring the Indian population. Now, one other thing which I would want to share here is that in the south, in the state in which I am, which is Tamil Nadu, and also in the neighboring state, Kerala, the Indian systems of medicine have also been utilized. There are certain traditional formulations. Now, in Tamil Nadu, we have a system of medicine called the Siddha system. And of course, throughout India, we have another system called the Ayurvedic system. Now, both these are very traditional. And there are certain formulations which have been found to be effective, at least as immune boosters. When we had the dengue episode every year these days we have the dengue episode. We have found one of the formulations called the Nilavembu Kudineer had been very effective in controlling dengue. And similarly, there are certain formulations, and we have what is called the Kabasura Kudineer, which freely translated would mean the drink to be utilized in any phlegmatic fever. Anything to do with phlegmatic fevers, this is a concoction which can be used. So this concoction had been used with kind of success reported from very many centers, at least as immune booster. This concoction is being given. Stage 0, the concoction is given. And even those hospitalized, moderate cases or mild cases, this concoction is given alongside the regular drugs, whatever drugs which are being used for symptomatic treatment of COVID-19. And associated, we also use other things like yoga, some kind of music therapy, aroma therapy, which is part of naturopathy, and also some exercises which are again part of the yoga and naturopathy regimen. Now, these seem to be having some kind of beneficial effect, at least on one side being immune boosters, on the other side trying to keep the psychological stress a little away from those who have been affected. So this is what we have been trying to do. And of course, on the research side, several researches are going on, and several projections have come out. And with about 67,000 cases, our government has already given a call that we will have to learn to live with the virus for some more months to come. And measures leading to that learning have all been initiated. And we are awaiting further instructions with regard to the lifting of the lockdown. That is the situation, a comprehensive outlook of the situation in India. Thank you.
Thank you very much, Sudha. Thank you. Thank you, panelists, for comprehensive reviews of what is happening in your countries. I see that we have several questions. We have overshot as well. We'll try and answer as many questions as we can. And the questions that we will not be able to answer today, we will try and see if we can send some over in our YouTube upload. Now let me look at that. I have a question from Mugahid Al-Hassan. What are the risk factors for death from infection with coronavirus? For example, compromised immunity. Can I request Sudha to take that question? Sudha?
Yeah, can you hear?
Yes.
Yeah. See, risk factors, as I told you, seem to be several of these comorbid conditions. Now, in India, we've seen two scenarios. One is that people above the age of 50 with other problems like hypertension or diabetes have shown symptoms and have progressed to moderate cases or sometimes even severe cases. On the other hand, people in the age group of 25 to 35 or even 40 with no other comorbidity seem to be completely asymptomatic. So the risk factor in COVID-19, since the pathogenesis seems to be revolving around endotheliitis, it appears any comorbidity is a risk factor for an individual to become seriously symptomatic and land in some complication.
Thank you. Thank you. The next question
I would agree with that. Age.
Go ahead, Ken.
Yeah, I was going to say, I agree with that. Age has been something we've found as well. Age above 50 has almost a 50% chance of requiring oxygen therapy. But we also found morbid obesity to be a concern. Those with underlying risk factors for coronary artery disease is something that we're keeping a lookout for, because there have been some reports starting to come on of sudden cardiac death associated with COVID-19 infections, and a predisposition maybe in those who already have underlying coronary artery disease as well.
Thank you.
Yeah, agree with that.
The next question is from an anonymous attendee. Have local licensing exams been resumed or planned for resumption anywhere? I'm in Pakistan, and we've been told off the record that the College of Physicians and Surgeons, Pakistan, will do so from late May or early June. Trainees are in no position to sit anything right now. They're redeployed and revision is clean off the table. Can I open that question? Hannah, what's happening in Malaysia?
Thank you very much. I think in Malaysia, it is similar. The moment that actually we declared this as a national emergency, many of the trainees have been redeployed to actually assist the preparedness of the country to actually overcome the threat of the COVID-19. We are worried about having a big tsunami following the religious meeting, knowing the numbers involved, also looking at the numbers of returning students from overseas, 32,000 returned from overseas somewhere in early April. We were worried about the third wave, but thank God for the time being, it looks like it's probably not going to happen. We managed to actually flatten the curve. So for the time being, all exams have been suspended for the time being. Similarly at schools, the national exam, a few of which have been declared, there will not be any standard 6 exam, there will not be a Form 3 exam, which is at the age 15. Some others will be postponed till next year. For our trainees, surgery, year 4, some of them has returned to the Ministry of Health to be redeployed in some of the quarantine centers or the Ministry of Health COVID hospitals. We will only resume in November for the time being. That's the initial plan, that November will be the time where we will have a new intake. Nothing will happen in between time. We do our teaching using online Zoom and webinars and so on, but no plans for the exam. Certainly, if we were to run the exam, we're still at the discussion phase, whether it will be the traditional method or we will have to actually alter the exam format. But that is a bit tricky because it involves changing the university regulation, particularly in the final years where it involves you graduating and be licensed. So university regulations has to change, and then at the same time, we have to make sure that it is safe to actually resume normalcy. So I think the earliest will be year end, but things are still fluid, it's dynamic. Things may change from now till November.
Thank you, Hannah. Can you give us your view of this new normal and how we're going to deal with education, examinations, digital platform? Because we in the college are extremely concerned about the trainees. And we have a whole tranche of trainees who are at the present time redeployed, like yourselves, who have had a standstill in their progression in training. They haven't had the same exposure for surgical procedures. And we also think that once we get back to near normal, the backlog of cases will mean that there will be a higher throughput expected, and whether we will have time for the trainees. So we are looking at a variety of suggestions platforms to help the trainees, especially the guys who are at the end of training, and also the people who wish to come into training. So I just want to hear from both you, Ken, and Sudha as to what your plans are in your own countries.
Thanks a lot. Actually, in the early part of the outbreak, we made a policy decision to continue with final year exams for undergraduates, if only because we wanted to make sure that we had medical graduates that could in fact continue to come into the workplace. Otherwise, there would be a potential shortfall of young doctors coming up the system. So we put in place measures to safeguard and prevent infection spread. And the 3 medical schools we have in Singapore successfully completed all their final year undergraduate examinations before we got really into the thick of things, managing COVID-19. But it's a problem now. We are starting to return undergraduates back into the system, starting with the more senior years. And we're paying a lot of attention to us, making sure that they are well trained in the use of personal protective equipment and infection control measures, hand washing, and so on. And we're doing this year by year in order to just make sure we handle the risk before we think about returning all medical students back into the hospitals. For training, it's been severely disrupted, particularly for surgical trainees, and at several levels. First of all, a lot of surgical activity has been curtailed. Non-essential work has stopped. While there still is acute surgery taking place in all the hospitals, depending on what comes through the casualty department, but it's not the full mix of surgery that we are accustomed to presenting to our trainees when it comes to training them to be surgeons in the future. We still carry on with cancer surgery because these would not wait for us in terms of continuing to have a good outcome. But in many of the other types of procedures that we expect our trainees to be highly proficient in, there's been, in fact, a shortfall in the number of cases that would come in simply because of our policy restrictions as well. We've also had many surgical trainees repurposed, so to speak. They're now managing medical patients, providing some backfill to allow other medical trainees to be deployed into ICU settings. So in that sense, it's been a significant hit for us in terms of assuring that these trainees can continue unhindered in their own surgical pathways. We reckon that it will be easily 6 months down where this would be an issue. They may not have the same training opportunities within that 6 month block, but subsequently we are still hopeful that we might be able to bring them back into the surgical rotations, give them the training and learning opportunities they well deserve, and then to allow them then to catch up from that perspective. Training still continues. They're still encouraged to log in their training hours through activities that are less dependent on face-to-face interactions. So a lot of small group tutorials are now taking place via telecommunication platforms like what Hana had mentioned. He had mentioned Zoom. That's one popular platform that's used. There's several others also being used in Singapore. And they're encouraged to carry out, to maintain their reading. And therefore, the departments in the hospitals are using different approaches to make sure that the trainees continue to read widely. They may be holding tutorials on an online platform, and we allow them therefore to use these to gain their continued professional education points. We credit them for that purpose, and it helps perhaps to allow them to gain credits to this, to give them some incentive to continue to keep current in their surgical knowledge, even during this period of time when they engage in support activities, managing an outbreak. We think that's important as well. We've mulled a little bit about exams. Some exams might be able to continue. I mean, if it's an MCQ exam, that's not a major issue. And it can even be done in settings, taking into account the fact that we are not wanting them to come together in a grouped setting. But what is more difficult to manage at this point in time are clinical examinations. And therefore, all clinical examinations have been suspended at this stage. And we may have, as we slowly resume training activities, to think of different formats that still allow us to carry out various clinical assessments, but perhaps with a lower risk of spread of infection, particularly when people might be asymptomatic but harboring this infection. We've also looked at OSCE type exams, and in fact, one of our specialties, emergency medicine, has carried out one of the intermediate exams in an OSCE format, but with a lot of safeguards. They've had to screen, put even their patients under quarantine before the exams. They were all tested before they showed up in the exam setting. We would not allow examiners coming from different hospitals in the same room, just to make sure that they weren't spreading infection between hospitals. And we were using even cameras to provide visual demonstration of what the trainee was going through in its interactions for communications, for example, with the examiner in a different room. So the different things that people have started to do, but the reality is that, in fact, the current formats for examinations may have to change to take into account the real possibility that even as epidemics settle in our individual countries, the risk of spread still remains, particularly from asymptomatic or minimally symptomatic people. And that will lead to a change in terms of how we would bring people together to engage in examination. But I don't think we've settled on a definitive position yet.
Thank you. Sudha?
Yeah, I agree with whatever that's been told. I would divide it into the postgraduate exams and the undergraduate stream. We have the postgraduates in India will have to undergo a 36-month training. And the people who had completed about 35 months, they had to take up their examinations in May 2020. They actually should have started by the 15th of May. But when COVID situation arose, all these people have been deployed to take part in COVID-19 activities, manage patients, and so on. So we have decided that we'll reschedule the examinations, probably, give them after they come back, after they get out of the COVID management duties, give them at least 8 to 10 weeks of time until they take up the written examination. Now, clinical examination is going to be another difficulty because, as rightly said, we need to have patients, we need clinical material, and we need to have examiners coming from one state or one city to another. So crossing the borders, we are not very sure if the borders would be opened out. We have interstate borders. We're not sure at all if these borders are going to be opened up for public transportation. So we might have difficulties. What we intend to do, we just have some kind of plan B. We could probably use some kind of virtual camera setup where the candidate, whatever the candidate is doing in the clinical examination, could be kind of screened to the examiner in a different city or a town. And if that would be feasible, then we would think of it as an option. With regard to undergraduates, of course, the classes have not suffered. 70% of the classes have not suffered because some kind of a digital platform is being used, and even their competencies, their training in competencies have not been happening for the last 3-4 months. So we need to catch up there, and no way thinking of any of those examinations until the end of the year. That is the situation here.
Thank you very much. I'll go on to some more questions. How much of your national strategies were based on WHO guidelines and recommendations? Hannah, you want to take this?
I think that question probably best addressed by Ken. I suspect, hearing what Ken was saying earlier, he's been in touch with our Director General of Health or his deputies very regularly, I suspect maybe on a weekly basis, because it sounds very much similar when I speak to them. But we actually use the WHO guidelines to guide us. Our Director General of Health always quote the WHO guidelines. We modify it if necessary according to the local needs. But I think the guidelines are pretty wide and broad, and is actually suitable to be used by ourselves. So I would think that very much so. And whenever it's possible, until we have some answers ourselves, I think WHO guidelines will be the mainstay of our references for the time being. That's my answer.
Thank you. Thank you. I have another question which I will pose to any one of the panelists from Stuart Clark, my council colleague. The overall mortality rate in the Far East appears to be significantly lower than in the UK. Do you have any explanation for this? Ken?
Well, I did mention a little bit of that when I first started sharing as well. I think it's partly a case mix issue in that we're seeing a lot more younger people where we are, and the mortality rates in the young have in fact been much lower compared to in the older population. So in part, it's a case mix issue as well. Secondly, you have to remember that in many of the countries in the East or the Far East, we've had a bad experience with SARS. And because of that, we in the last decade particularly, we've been steadily building infrastructure in preparation for future pandemic or highly contagious infection. So in that sense, when COVID erupted on our horizon, many of us already in our own countries had infrastructure, we had ICU capabilities, we had isolation rooms. In others, we are a lot better prepared than some other countries simply because of our previous experiences. And I think that was also helpful because it meant, therefore, that when people were starting to get sick with COVID-19, access to care was much better than in other countries. And therefore, that also helped, I think, in providing a good quality care coming in. Early diagnosis, I think, is still important. There are countries where, unfortunately, there have been areas where perhaps access to care has not been good, diagnosis has been late, and eventually, by the time you in fact can intervene, it's very difficult to do anything to improve our outcomes as well. There's been speculation whether the nature of the disease is different in the East versus in the West. But at this point in time, we really don't see any evidence of that. And therefore, we think it's partly a matter of the case mix, perhaps the quality of care that's provided, access to care, and just that perhaps those of us who've had a bad experience with SARS before, we were perhaps better prepared for this outbreak as it arose in our own countries.
Thanks very much. Thank you. I have a question from Chelaya Selvasekar. India has done well with the lockdown, but the concern is post-lockdown corona transmission. Any strategies planned? Sudha?
As I told you, we are thinking of a kind of layered lockdown. The restrictions would remain. Public transportation probably would carry less number of passengers, and office timings would be restricted. The industries, organizations, companies would all be permitted to work only with about 1/3 of their regular workforce. Now, these are the things in offing, and physical distancing norms in the social space, and probably malls and cinema theaters will not open at all for some more months, thereby restricting people from getting crowded. So those are the norms which are being thought of, and maybe a few more things will evolve as things take shape. This is right now a little fluid and dynamic. We've still not completely evolved the whole policy. Maybe in a day or two, it will get finalized.
Thank you. Thank you very much. There's a question directed to me here. It says, are the MRCS exams going to be conducted as scheduled from September? If so, what would be the plan for those who had applied for the April session? From Akash Venkatesan. Akash, I am very sorry to inform you that we have suspended all examinations for the foreseeable future. And the reason for that, I'm sure you've been listening to Hannah, you've been listening to Ken, and you've been listening to Sudha, that every country has its own rules and regulations about entry, about quarantine, about the way the exams are being held, overseas examiners. So until such time as we are in a position to have some form of clarity, I suspect that the exams will stay suspended. I hope that this is a reasonable answer, but I can see the frustration among so many of you young people, and we will do our best to get a solution for you as soon as we have more clarity. Adish Babu asks, have any risk factors been identified in young doctors who have contracted the virus and manifested severe symptoms and have died? Ken?
Unfortunately, I have to say that we've got no healthcare workers who have had severe illness or have passed away in Singapore. So I have no personal experience from what we are dealing with in Singapore to answer this question. I would imagine the risk factors are not different from the risk factors that have been mentioned earlier in the general population, the older patients, those with chronic illnesses, particularly if they're immunosuppressed or immunodeficient, those who are morbidly obese. But for young doctors, we've not actually identified any specific risk factors.
Rajesh,
Yes.
it could be that the viral load would be higher in the healthcare professional. More exposure, the viral load could be higher, and that could make them prone for more complications.
Okay. So thank you ever so much for this fascinating webinar. I hope to stay in touch with all of you, and hopefully we will be in a position to get some more of the answers which, from the questions which I've got here. But unfortunately, we've been run over by 35 minutes now. So that's how interesting this webinar has been. Thank you ever so much, Hannah. Thank you, Ken. And thank you, Sudha. And hope we will meet sometime in the foreseeable future after this COVID crisis is over. Thank you very much.
Meet in person.
Thank you. Yes. And thank you, all the attendees. Thank you very much.